thank you so much, Michelle. Thank you. Hello, everybody. Thank you for inviting me to this symposium. I think it's so great to be back to the GIVD and really listen to real-world experiences, not having to have all these lectures about papers and science and everything. So it's great. And this is all about GIVD and mechanical insufflation, exsufflation tales. That's what my lecture is about. That's what the challenge that Michelle gave it to me. And as all tales, we have to start with once upon a time. And once upon a time in a world of MIE. Now, MIE, and what I want to, I'm going to make a reflection with you guys, because we know that MIE works. We know that MIE at this moment, we don't need to convince anybody that MIE is a life-saving technique for neuromuscular patients. As respiratory therapists, we have the power to take these secretions out. We have the power to take the secretions from the lower lungs, from the middle lungs, from the upper lungs, from the upper airway. We have that power. But again, like all power, we need responsibility. And to give this responsibility, I think that we should be responsible on what we know. But I think that we arrived here today in 2004 because many people, they left their comfort zone. And this is the reflection I want to give it to you. We have our comfort zone, and the comfort zone is where we stay and feel secure. And look at what we saw with Jeanette. She really is out of her comfort zone. And this is really what makes practice, clinical science evolve. We go from the comfort zone to the learning zone. So what this symposium is all about is taking your head out of the sand, taking yourself out of your comfort zone, and thinking outside the box. This is really what we want to achieve with this symposium. And speaking about MIE, there's several steps that we need to go through. And first, the first zone that we enter when we get out of our comfort zone is a fear zone. The fear that we cannot make it. The fear that we saw these beautiful lectures in the GIVD and we go back home and we are afraid to use it in our patients. That's why we need to learn. We need to go to the learning zone. We need to acquire new skills. We need to extend our comfort zone, and then we grow. And when we grow, we can explore the real potential of this technique. Now, I agree that many times we feel like we are in an abyss. We feel like the train is coming out and we are not feeling secure. So we must have some kind of leap of faith when what we are now and what we want to be. We should make the jump. And this lecture is about to infinity and beyond. And this is a Buzz Lightyear quote. So what I really want to do with you is to bring MIE to infinity and beyond and take you out of your comfort zone. Now, for you to leave this room convinced to leave your comfort zone, you need to first learn and first be comfortable with this that we're going to say. Because Buzz Lightyear is a superhero, and he doesn't know that he's a toy. But what we're really doing is, what MIE is really is a technique that depends on the machine. And the machine can also be a superhero. The machine can, the machine can really take all the secretions and leave the secretions out and permit that the patient can breathe clearer without any obstruction. Now, the first example that I bring you is from Japan. Now, you all, I don't know if there's any Japanese in the audience, but I love Japan. I'm going there in May. And they are great because they continue to eat. And you know Japanese with their food, you know. And for us physiotherapists, if there's a type of food that is really difficult to get out of the lungs, it's sushi, right? But they continue to eat. And sometimes we may have this problem. We may have these patients, these neuromuscular patients that you're seeing here, these are two Duchenne's with totally ventilatory dependence. They eat with a mouthpiece. So there's always a risk of aspirating. You know what they do? They do MIE. So every Japanese that eats has an MIE device. It's, well, now it's not called anymore because in the old days we call it MIE the cough assist, but really this is the choke assist. This is using MIE. Now, okay, this is a special lecture. Don't leave this room telling that Miguel Gonçalves says that MIE is as indication for choking. No, we are just exploring the limits here. If a patient that is eating and he likes to eat, but he has risk because he's 24-hour vent dependent, he has a risk of aspirating, why can't we use, what do all we do when we choke? We cough. If there's a machine that can cough for us, why not? And we can actually, we do the Heimlich maneuver, right? Every time we choke at something, we do the Heimlich maneuver. Why can't we do the Heimlich maneuver, the chest compression, while we are doing MIE? Okay, so this is really the first message. MIE can be used also. And I'm using here the thoracic compression because, of course, if the patient is eating, you will not want to do abdominal thrusts because you can provoke the vomit. Now, one of the main challenges from the last 20 years in using the combination of non-invasive ventilatory support and MIE is children with spinal muscular atrophy type 1. Now, the game has changed for these patients. The paradigm is completely different. These beautiful, smart, intelligent kids that 20 years ago were condemned to total paralysis and even death, they now have medication that can save their lives and that can make them more functional and without any danger. But even though they have this danger, they need to be accessed. So what I'm bringing to you is trying to convince you that these kids, sometimes they go to the ICU and going to infinity and beyond, we can transfer this patient back to non-invasive ventilation without using a tracheostomy tube. Now this kid here, she's 8 months old, and this was before she got medication. Her system and the country that she lived in did not approve medication for tracheostomy patients at the time. Now it does. So at the time, the parents were confronted with the dilemma of trying to extubate their child with a loss of danger and get the medication, or perform a tracheostomy tube and be without medication. So the parents were resilient and they did not accept the tracheostomy. And the intensive care doctor said, okay, we can try to extubate her, but she will fail in the first hours because she can't cough. Now here comes mechanical insufflation, exsufflation. Here comes the superhero to this scenario and helped this 8-month-old kid to clear the lungs through the tube. You can see here, she's 8 months old and she's doing 60 to minus 60 centimeters of water through the inexsufflator. You can see the chest coming up and coming down, and with 60 to minus 60, the kid does not explode, does not levitate, does not have any trauma, and the kid, this was crucial to successfully extubate this child. Then, the first time this kid got contact to NIV was here. So the most important person in the room at this moment is her mother. It is her mother that will teach her that, and these kids, even with 8 months old, they are very, very, very smart. So the mother is teaching her that she will put a mask on. And then, with the mask on and the ventilator connected, we take the tube out. And the tube comes out immediately before and after non-invasive ventilation is turned on. So the kid does not have any distress in having some kind of spontaneous breathing trial. Then, because it's maybe difficult to continue to do exsufflation in this kid because she can't cooperate enough, she continues to do physiotherapy, and because she did a lot of exsufflation through the tube before she got extubated, this permitted her to stay on NIV in intensive care. She went home out of intensive care. Her brother takes good care of her, and this is all the timeline. She was 8 months old. She went to school. Okay, here you can see her baby sister was born. Okay, and the parents, like Jeanette, no, of course, there's no ski in the country that she lives on. There's no snow, but they also try to take her in several types of activities, even riding a horse. She's completely paralyzed. Here she's medicated, but she's still paralyzed. And here her physical therapist giving her the experience of walking, and he has this special design where the foot of the kid is connected to the foot of the therapist, and under non-invasive ventilation, she takes her morning walk every day, goes to school, and even goes inside the pool to do some kind of aquatic physiotherapy. And this was all possible thanks to the possibility that we gave her to be extubated to non-invasive ventilation, thanks to the mechanical insufflation, exsufflation. And that's why we now have a lot of patients with SMA type 1. The medications on the market now have completely changed the paradigm. We have new responsibilities towards these kids. And despite the children are being medicated, they're still dying. These kids are still dying in the ICU. You put $2 million shot in their blood, and you let them die after 2 weeks. This is not acceptable. These kids, even though they get stronger, even though they are not so dependent, they still need access to NIV and the Exsufflator. Okay, this is a very, very important message that I want to give to you in this symposium. The second case is also a little bit to infinity and beyond. This is also an SMA, but type 2. And he had jaw problems. So the jaw surgeon went to operate on him, and he said to me that he would be intubated through the nose, and for us to extubate him, we had no access to the mouth because he will be operated to the jaw, and the jaw would be inaccessible to secretions or ventilation. So of course we had the machines ready for him to extubate him as we want, but he arrived like this. He had his jaw bloody. He had this cold patch on him to do anti-inflammatory. And we knew that this was not a problem because we can still use insufflation, exsufflation through the tube. No matter where the tube is, the tube can be in the mouth and can be in the nose. But we continued to use the exsufflator through the tube. The tube is no problem. Now, of course, the most easiest thing to do in this patient is to trach him because I had no access to the mouth. Now, but as Buzz Lightyear, I'm a little courageous. So I thought to myself, why should I trach this patient just because I can't access to his mouth? Is it possible to use, after we take the tube out, we use the exsufflator through the nose? So I trained him to use the exsufflator through the nose before he got on surgery. So it's not easy, let me tell you. 40 to minus 40 centimeters of water through the nose, it's not easy. But again, In the last example of the Japanese, I presented to you the choke assist. Well, this is the sneeze assist. You do the inexsufflator through the nose. Now, this was crucial because I had, again, no access to the mouth. But the patient was so comfortable of doing these techniques through the nose that after we extubated him, we did some breath stacking. So we took the air through the nose. He did inexsufflation through the nose. He was extubated to nasal ventilation. Breath stacking through the nose was crucial. Inexsufflation through the nose was crucial. The mother helped a lot. The mother is used to do abdominal thrust and thoracic thrusts on him and to help him cough. And after the secretion, then the bloody secretions were out, the patient continued to be on nasal ventilation. Then the jaw became better. And let me tell you, before he got on surgery, he told me, you know, Miguel, I will go in surgery. I know you'll take my tube out, but I have my favorite rock group that will perform in my city in a week. So I said to him, listen, you just got surgery. You'll get surgery. Even I'm afraid of what was going to happen to you. What do you mean you're going to go to a rock concert? So he said to me, no. I know you will extubate me. I know I will not need a trach. And I already got the tickets. And my friends will take me. And this is a guy that is completely resilient. Look at his tattoo. He thinks he's the evolution of the species. Okay? So we extubated him. We did exsufflation through the nose. He was successfully extubated. He had no problems. And I went home. And after a week, he sent me this movie with his friends on a rock concert after having this tremendous experience in the ICU. So again, the best way really to teach and to inspire is to have examples. And I feel so inspired by the examples I've been seeing in the GIVD for the last 20 years. From this symposium, I feel so inspired by Jeanette's talk about the Tetra ski. And we really think that to infinity and beyond is really what we need to do to leave our comfort zone and not be insane. This is not insane. This is really breaking the boundaries. And Einstein said, this is my favorite quote of Einstein, I always use it in the end of my lectures, insanity is doing the same thing over and over again and expecting different results. Now, in this type of patients, physiotherapists, they worry a lot and they think it's very stressful. But I believe that if Einstein had the opportunity, he would also want to use the inexsufflator to infinity and beyond. And Einstein said there are two things he thinks it's infinitive. The universe and human stupidity. But he was not sure when regarding to the first one. And that's Einstein. Thank you very much for your attention.
Thank you, Miguel, for an excellent presentation and actually taking us further forward than we've ever been before. While I'm sure there are questions from the audience, but I've always got 10,000 in my brain. Practically, when you are using MIE through a nasal tube, in theory, you would expect, because the tube is narrower, that you would have to go up on the pressures to overcome the resistance. But I noted that you were quite cautious. And were you cautious because of the surgery, or there's something wrong and you're feeling a bit unwell for you?
I was cautious because I was in the dark.
Okay.
I never experienced that kind of patient in my life. Now, I've been using 60, 70 through very narrow tubes in SMA type 1s. They are very narrow. But here, I had all the mouth, the oropharynx, the jaw, were bloody, were with suture. I was afraid that, and also, as you can see, the patient, he had some kind of chest wall deformity. So I was afraid. One thing is he was using 40 to minus 40, 50 to minus 50 at home. So when I started him on nasal, I started with 10, 20, and then I actually had to use a corticoid, nasal corticoid, for him to clear a little bit the nose, because the negative pressure collapsed a little bit the nose. After he felt the nose obstructed. But through the tube, the highest I went was 50.
Okay.
And it worked. And I just needed like 24 hours to clear the lungs. But my fear, was after extubation.
Yeah.
It was really after extubation that I was completely in the dark.
Yeah. And I think that's a really good message, that you start off low and you build up to what is effective. You don't need to go in massively high.
That's right.
Now, I know that Jeanette had a little bit of a palpitation at one point when you were doing your SMA type 1. With pressures of, I think you had 60 and minus 60. Mm-hmm. And maybe you'd like to sort of talk a little bit about that, because my personal view when I've seen that is that you're not actually reaching those pressures.
We use higher pressures because we have to overcome the resistance of the tube. Now, this kid has a 3-4 tube. He was a very, very narrow tube. So I'm convinced that, and we are looking at now with electric impedance, really what's going into the lungs. Now we have that technology, but at the time we hadn't had that technology. But I had the feeling that the child was okay. He was not complaining. And I had the feeling that we are not giving 60 inside the lung. At least 30 to 40 was inside the lung. The other was to overcome the resistance of the tube.
You highlighted with MIE that the airway can collapse, and in this instance it was nasally, but in some patients that are so weak and acutely unwell that you might not want to might want to give airway clearance a shot before intubation. Do you have any tips to maintain the airway open when using MIE to make it more effective?
Well, this really happened. Sometimes it happens with SMA type 1, but most of the time it happens with ALS. Now, I thought that severely bulbar ALS was the problem, but I figured that now, because the Duchenne's are getting older and other neuromuscular patients are getting older, we are starting to see this collapse in other neuromuscular disease. And the group of Tina just came out with a paper that she found that it collapses even in healthy subjects. So the upper airway is now a Pandora box that Tina opened for us, and we need to study it more. I can't tell you honestly any tricks in this type of patients. I go back to the old school. I try it. I try MIE. I put my stethoscope in, and I see if there's some kind of stridor, and if the airway is not open, I try to modify the parameters. I try to look at the curves. I don't have laryngoscopy. I don't have, some of the team is now looking at learning how to use ultrasound, but we have a complete field of technology now that can help us. In the old days, as when me and you,
that's twice today I've been called old.
No, but like 20 years ago, we just depended on our clinical feeling. And I think in our clinical feeling, it's still, we should trust it.
I mean, we had good experience in acute care with Goodell Airways in this group of patients, just for a temporary period in order to get the air in and the air out and suction easier.
Yeah, sometimes you have edema when you extubate. Anyway.
Microphone. So we have a question from, good Lord, we've got two. Would you like to go first? Sorry.
So I have to say to you, thank you, because I feel relieved now, because I have a patient like the one you have. So one day he asked it to me, are you able to adapt the cough assist? Because I want to do it by myself. It's an SMA patient type 2, 43 years old. Even though he's not doing it because he needs someone to help him. So okay, well, we will try. I have to adapt a mask with strap. And he told me, take my BiPAP mask because it's a nasal mask. Okay, so we tried. And it works well, I have to admit. And if I don't do these steps with him, he will do it alone. So I prefer to practice with him. So
That's SMA, yeah.
Yeah, so we have to go with them. So that's funny because this time he's using his cough assist 2 times per day, but only in the inspiratory pressure, mostly to do recruitment, and if needed, it's using in its pre-expiratory phase. So I'm really happy because, sometimes you feel guilty to go with the patient, but we did we analyzed the risk and what kind of risk we have to do that. The collapses, but it wasn't there.
No,
So.
don't feel guilty because Jeanette also has this experience.
Yeah.
These patients, they are disabled. They know they are disabled. But the best blessing that you can give them, the best thing that you can give them is called autonomy. They want to control whatever they can control. What they can't control, they know it.
Yeah.
But if they found something that they can control without asking nobody to help them, they will grab to it. Now I have an advice for you. Many of these patients, most of my patients using mouthpiece ventilation, they can cough just by grabbing the mouthpiece, air stacking to the maximum insufflation capacity, and they can cough. And they only need the exsufflator when they are very, really sick. So one of the things that sometimes I use the mouthpiece not to ventilate, but just to give them the autonomy to cough when and how and whatever hour they want.
Yeah, we are in the same situation, and also I think my patient will be disappointed because he's not the only one who's doing that. That's the other point. Thank you for your thought.
It's a new fashion. Yes.
Thank you so much. It is, I think, encouraging all of us to go infinity and beyond. So I'm going on the other side of the spectrum now, from the SMA to fibrodysplasia ossificans progressica. I have one patient, and I'm not sure what the experience is for the audience. It's the Stoneman disease. I always worry I just have one patient, there's not much in the literature. How much pressure can I give through cough assist? In that situation, I've gone up because he was comfortable going up to -60, but in my heart, I'm like, am I doing something wrong in that situation? Is it causing more harm? Because it's such a restrictive thoracic from this calcification. So I just wanted to see what everybody's opinion is about that. And also, from the ventilation standpoint, how are you managing those patients, if anybody has experience with them?
Listen, 10 to 15 years ago, I was all about high and high and high and high pressures. But I learned, I left my comfort zone and I learned that most of these patients don't need such high pressures. They need the pressures that they need to cough. Some patients need 40, some patients need 50, some patients need 60. Now, I didn't quite get the diagnosis that you were talking about, but it really doesn't matter because if it has lung disease or if it doesn't have lung disease, if it has upper airway collapse or if it doesn't have upper airway collapse. Now, if you're talking about lung disease patients, you should worry about trauma, lung trauma, bowel trauma, volume trauma, pneumothoraxes. You should worry about this stuff when they have lung disease, airway collapse. So you should analyze very well the lungs of the patients and see if the cough assist is a mean to the end.
Miguel, this patient's got severe
this one-
restrictive disease.
No lung disease. I thought it was
So there's no lung disease in
Oh.
it. It's just
Restrictive.
calcification
Okay.
of the muscle that happens.
Then
So there's
with very restrictive patients,
Yeah.
the problem is
the lung
pain.
volumes.
Pain.
Yeah, he's been okay for now, but yeah, I was just trying to gauge the audience and see what other people have experienced.
My advice to you is if there's no lung problems, if there's no upper airway collapse, use the pressures that is more efficient for the patient. And you have to balance the efficiency and if the patient is comfort or not. If you achieve that balance of efficacy and comfort, you have the best therapy you can give to your patient.
Thank you.
I think we've got one more question at the back.
Okay, real quick question. When you're doing that, it looked like you were using manual mode most of the time. I try to use auto mode on most of my patients just for autonomy and also ease of caregiver. because on manual there's so much difference with caregivers. I am curious about when you're using higher pressures. I'm on my bulbar onset patients, I'm trying to slow my flow down a little bit. So I'm using longer inspiratory and expiratory times.
Yep.
And I have cough track turned off, and I'm using a timer because of the bulbar onset. What are you doing eye time wise? Are you like 1.5? Are you 2.5, 3.0?
Well, let me tell you, like 50 to 20 years ago, when John Bach came out with his first papers, we followed his recipe. But the recipe we learned from to today, that the recipe has all chefs need to be adapted to the cooking that you are doing. So again, when you are setting up a patient, the patient has to be titrated to what his individual needs are, and according to the diagnosis. Even in the ALS group, there are ALS that are different from the others, the Duchenne's, the spinal cords. So, of course, when there's bulbar involvement, you need to have longer exsufflation times, you need to have a flow that is low or medium. Sometimes the cough track works, sometimes it doesn't. Sometimes higher pressures work only on insufflation and not on exsufflation. The timing is also worried. Now you have curves that you can see. So it's really now we are now convinced that we should set up a patient on NIV in a lab, because you have a synchronies, you have all this type of stuff. But we are going in a way of also using a lab to titrate MIE. So it's really individual basis. But I completely agree with you. The bulbar, we need some kind of titration that is according to their needs. Now, regarding automatic and manually, normally in the ICU, I like to control, but it's me that I'm using it. The caregivers and the patients, of course, they prefer the automatic mode. And this is also a challenge to the industry. If the industry can make some kind of joystick that the patients can use themselves. I know there's the pedal, there's the switch, but if the patient can use their head in an X or something like that, if the patient can have more autonomy on using the exsufflator, I think it'll be great for them.
I'm going to let Lisa have the last question before I wrap up.
Wow, thank you. Hi, so I guess it's not really a question so much as like a thought on the tips and tricks. So Christine DiDonato, who has the animal model for the SMN gene, says that the jaw thing is in the animal model too, which is interesting. They've never published it, but it's there. So it's part of the mutation. So I think it'll be interesting to see, as we're giving gene therapy, if the jaw thing gets better. And your picture was fabulous, showing the first thing we need to ask about during adult transition for SMA is wisdom teeth.
Yep.
Because those wisdom teeth are a nightmare. But what I was
and they like to eat,
right?
So they can't bite. It's terrible for them.
Yeah. So one of the things we've done in this situation for maxillary mandibular osteotomy and SMA is to work with our oral maxillofacial surgeons to do 3D reconstructions prior to surgery and ask them to improve posterior pharyngeal and upper airway space. And what we find is that we have to change our NIV settings post-op because they actually breathe better. And we can drop our EPAP significantly. So I'm just interested if you've talked about posterior pharynx and looked at NIV post-op.
You know, I never thought about it. When I go home, I will ask the patient if he breathes better, because I never thought of changing his parameters, because I never thought that the jaw would have influence, because it was not the jaw was, he put a prosthesis that he can open better, but I never thought that the jaw was pushing the larynx back and may create an obstruction. That's a very good point. I never thought about that.
And pre-op 3D reconstruction with those guys, it's amazing.
I'll tell that to the surgeons.
So I'd like to thank you all for coming to this session. I'd like to thank our speakers for 2 excellent presentations and being totally inspiring. Hopefully, you'll have a tip for your practice, or if not, a telephone number to get to the ski resort. Thank you.